Hello, everybody. Welcome back once again to the interview series here on the channel. I am delighted today to be joined by Dr. Rory Tinker, who is going to be talking with us about going to work in the US, essentially, isn't it? And matching into residency and all the processes that come along with that. Thank you, Rory, for coming on.
Thank you for having me. I'm excited to hopefully be of use to some people out there.
It was a really, really popular subject that people wanted discussing with an expert. And just for some background context, Rory was an obvious choice because right when I graduated as a doctor and started working in the NHS, you were just on your way out, weren't you, essentially?
Yeah, I was jumping ship just as you were joining the ship on.
Yeah, it was like the Titanic going down and climbing up. So it might be just best to start, Rory. Could you just briefly run us through your kind of medical education journey and how you got to where you are now?
Yeah, so I'll just give my background, I guess, is the easiest way to say it, and then that will lead on by extension to why I left the NHS to work in the US. So my name's Rory. I'm originally from kind of the outskirts of London, the suburbs there, near a place called Watford. So if anyone's ever been there, then that's where I'm from.
Into Harry Potter world or whatever.
Harry Potter world, exactly, yeah. So that kind of a big part of the world. Anyway, and I was the kind of person who went to medical school exclusively because of I was relatively good at chemistry and got relatively good grades. I didn't have any big passion for medicine, and I think I'm happy to lay that out. And I didn't. Then I went to Manchester University, and I didn't really have the happiest medical school experience. I found the process very infantilizing and patronising, and just felt useless much of the time. So that was kind of my background. And I was fortunate to get great mentorship in certain sub areas. So there's a great paediatrician called Pat Graham who really took me under his wing and mentored me in paediatrics and showed me what a wonderful specialty that could be. And I got great genetics mentorship from a guy called Professor Sid Banker and a guy called Professor Bill Newman. So I kind of got this a completely dissatisfaction with medical school, then got excellent medical mentorship in kind of genetics and pediatrics, and just showed me how filling those specialities can be. So I went for medical school, didn't really enjoy the process, got to about the fourth or fifth year, and I asked myself, I guess what I want to do in my career, because I saw the NHS and I saw how brilliant and intelligent and fantastic junior doctors were, whether they were F1, F2, registrar, that kind of level, but they were just doing a lot of the time low-grade clerical work in the context of dysfunctional organisations. I don't know if Ollie, you've worked in NHS. I don't know how you feel about that.
I think that's statement. A very, I think I'd never be so, if I was at work, I'd certainly never be so open about describing it that way. But actually, that's a fair assessment. And that's a generalisation.
A lot of times you do get very exciting clinical moments, and very interesting, but that's in a backwash of just general service vision in your training is probably the more diplomatic way of putting it.
Sure, that's fair.
Yeah, so I kind of saw that picture in front of me and I thought, is this really what I want to do? The best years of my life professionally, which is probably the 25 to 35 period, the time when you can really establish your professional identity and what you want to do. So I kind of looked at the options available to me, and one of them was to leave medicine completely and make money and finance or something like that, which I think is much easier said than done. I know people go on about that. Another one obviously would be to go to Australia and be an SHO, which is a good option for people. And then I kind of always at the back of my mind working in the US, because I love pediatrics and I love genetics. So it's very purposeful what you can do in those specialty areas. Like I'm sure you love neurosurgery, Ollie. So I had those thoughts and I did a bit of research and I was very intimidated by the USMLEs because I think it's got a reputation of being a very tough exam. It requires a lot of time, lots of money, and lots of focus. So that kind of put me off doing it towards the end of medical school, and then I finally said, look, if I don't do this now, I'm going to go to start work, be very busy, I'll never quite have the bandwidth of my life to do this. So I subsequently did my USMLEs in the final year of medical school, basically, and then I moved into my foundation job in Newcastle, where I met Ollie. So I was fortunate to get an academic foundation program position, and I really loved my research side of that. I was working at a world-leading mitochondrial genetics research institute and got fantastic mentorship from a man called Professor Bobby McFarland, who is world-renowned mitochondrial geneticist. So that was fantastic, and I got great exposure and great mentorship. Then I went on to my F1 experience, which kind of confirmed exactly how I felt. I was unhappy professionally. I was just left alone to run acute medical wards without really any mentorship. And then I was left alone to run a acute surgical ward where I met Ollie. And in those experiences, no one really cared about your professional development. I just felt like I was a body on the rotor, just there to run the hospital as a nebulous personality. And I don't know if that's the side effect of the system. I don't think it's anyone's fault. I just think it's the way the NHS has become structured. So that's kind of where I was. So then at the start of F1, I applied for the match process, and I interviewed at various programs across the US, and I was fortunate enough to match into Nashville in Tennessee at the University of Vanderbilt, which is kind of where I'm at now in my life, and about 7 months into residency. And I'm professionally quite satisfied. So that's kind of my big picture.
Your story. Well, there's a huge amount to unpack, and actually this is one of the areas where the people who I canvassed for questions on social media, they sent in lots of very specific questions. So I've tried to tease out the core themes, and you've mentioned the USMLEs a couple of times. So why don't we talk about that first? Yeah. What, for those, I think those who are kind of aware that you can go and work in the US once you leave medical school have heard of the USMLEs of step 1, step 2, and step 3. But what actually are these things?
So the USMLE is a series of exams in the US which you need to become, if they call them their boards here. So you need them to practice in a hospital of medicine. And as an IMG, we call it International Medical Graduate, you need to do these exams basically to practice in the US. And there's 3 steps. So the first step exam is kind of more basic science, a bit of esoteric information. But still has a clinical context. And that is a 9-hour exam, which you do at a Prometric Center, costs about $1,000. And we can go through ways to the various strategies for revising that in a moment if you guys would like. The second exam is then called Step 2 Clinical Knowledge, which is kind of a more final style UK exam, which goes over kind of basic clinical medicine and across surgery, pediatrics, the whole bag. So it's very similar to UK finals. And then you have Step 3, which is kind of a postgraduate exam, which you need to practice independently in the US, which most residents do after residency or during residency. But you have to do it if you want a Pacific visa class, which we can again come on to later. So, and that's all at Prometric, which is this test center. You can do Step 1 and Step 2 in the UK. You can only do Step 3 in the US. So that's kind of the picture. There used to be an exam called Step 2 Clinical Skills, which is a bit like a big OSCE, which was very expensive. It cost like $2,000. You need to fly to America to do it. It was a bit nerve-wracking because you had to deal with these like really bad US actors. But luckily they've scrapped that and they replaced it with a language test. So you need to go along again now to do a language test. I had to do the CS, but don't anymore. So there's a kind of 3 exams. Do you have any specific questions, Ollie, from any of your listeners about anyone? Or
I think I do, and I just want to illustrate the difference because a lot of people. I think it's worth illustrating the difference between almost the purposes of these exams and how we do things in the UK, only in the sense that when you take your medical school finals, it is essentially a matter of pass or fail, right? And it has no further impact on your life. Whereas the step exams, I think it's fair to say, are much more high stakes.
Yeah, so when you take a step exam, you get scored for the exam. So you get a number which is for some reason is averaged out about in the 240s. So it's called your score, and it basically ranges from 200 to 300. 200 if you fail the exam completely, 300 if you got every question right, and it's like a normal distribution. So you get, whenever you sit a step exam, you get this score on your transcript, and that score is used as selection by residency programs, rightly or wrongly, because it's a system they've developed. So the good news is for UK trained doctors, the most intimidating exam for us, which was Step 1, which would have silly questions about glycogen storage diseases, which you never see as a clinician, is that's now become pass-fail as of January. So that removes a lot of the burden for UK doctors to sit their step exams. As the exam that was most disproportionate to our training, which is very clinically orientated, rightly or wrongly, has now been made a pass-fail. So you need to invest a lot less time in getting a good score for that, because previously that was a major selection. So I think a lot of UK graduates had to put a lot of time just to learn a lot of basic science and anatomy that we just don't get taught outside of maybe Imperial or Oxbridge programs. So that's removed one of the big burdens of training in the US. So you just get a score for that, and then you get a score for step 2, clinical knowledge. But as a UK trained doctor, I don't feel that's that particularly difficult an exam. I feel I was pretty well prepared for it by the end of medical school. So I'd recommend you sit that basically at the same time you sit your finals, and we can talk about the resources to use for steps. And then step 3, I wouldn't worry about unless you want to do a visa. You just want a specific visa type, which we can discuss later.
Sure. And then I think you talked about selection there. One of the big question areas that came in is what is this, the match? What is matching into residency?
Yeah. So matching is effectively this big website called AWAS. I don't really know what that stands for, but it's this website where you effectively upload your portfolio. So you'd upload your step scores, you'd upload your personal statements, you'd upload your letters of recommendation, which is a UK version of a reference, but it's in much more detail, so it's a bit bizarre. And then you'd upload any publications you had, any posters you presented, any extracurricular treatments. So it effectively generates a giant resume for yourself. And then you take this big collection of who your personality is, and you take your big collection of your CV, and then you send that to the residency programs you apply to. And it costs like $20 to apply to each residency program. And then the residency programs get all this information. In theory, they read through it. There's some applies arbitrary selection criteria, and then they offer interviews, and then you accept the interviews. And then basically you'd interview at how many programs you'd like to, how many you get offers for. And then what you do is you take the list of programs that you apply to, and you rank them in order of preference to ones you go to. So we then they then rank you, so they then rank for applicants, and there's kind of this big crisscross. There's a fancy economic term for the selection, which I can't remember, but it's applicant preference. So the first line, so the top rank, so the applicants kind of get the first dibs, if that makes sense. There's lots of videos on YouTube that explain this much more eloquently than I can.
So you're saying that the residency programs can express who they like, but ultimately what matters more is where the applicants really want to go.
Yeah. So it's an applicant-led algorithm as opposed to a program-led algorithm. So that will suit its preference in its selection, and that's how they select. So some people say we should move to a more traditional. You apply to jobs and get off a job system. As they say, the match is broken. But some people think it's a really good way to kind of center both preferences. It can be quite expensive because let's say you're an IMG, which you're naturally it's harder to get into residency as an IMG, and you want to go into a competitive specialty, you may have to apply to 50 to 100 programs, and that can be thousands of dollars. So that's another question for the match. That's kind of the process.
Sure. And before we move on, I mean, we talked about the role of the step exams in selection. Yeah. Certainly, speaking as someone who personally has never had much interest in going to America, but so I'm interested in surgery and neurosurgery, as you know.
Yeah.
I was always under the impression that certain specialties required a much more competitive step score. And not only that, but as an international medical graduate, you had to be even better than the best US applicants to prove yourself.
Yeah. Obviously, if you want to do neurosurgery at Harvard, you have to be an exceptional applicant. But I think it's probably worth going over for people watching this video, the kind of stuff programs select on, which obviously I can only say from my own experience. I've never selected. So the first thing is your steps. It's an arbitrary number. Programs like it, it gives them a way to compare between people. So if you want to go to the US, you probably want to do as well in your step scores as you can. I think it's an advantage now for UK trained IMGs that we don't have to sit step one. Step one's pass fail, so you don't get a score. So you want to do as well as possible in step 2, CK. And I think the best way to do that is to do it with your finals when you have the best general medical knowledge. And there's good question banks for steps, which is called UWorld, which is very good. So I use that. And there's a book called First Aid, which is really good. I buy First Aid personally as a medical student. It's like the most concise collection of knowledge I've ever read in a textbook. And it's designed to be user friendly. So that's my 2 tips for the step 2 exams and step 1. And you can also do step 3, which we can talk again. That's apparently makes you a bit more competitive. So that's one selection, is your scores. So,
well, I was going to say, how did you, I mean, medical exams or your UK med school exams are hard enough, you know, and people struggle to do all the revision and everything else that they need to do for those. How did you find studying for the USMLEs, which presumably is a completely different curriculum?
So my approach was I'd try and kill 2 birds with 1 stone. So I'd sat it all my USMLEs around the same period. I sat my UK finals, and I feel by using UWorld as a question bank for step 2 clinical knowledge, I did quite well in my UK finals as a consequence. It's a very good question bank that's very thorough and very detailed and covers everything, every part of kind of clinical medicine. And it's a bit better than stuff like PassMed, as it kind of tells you why an answer is not right and then gives you information of why it's not right. So it's a really good learning tool for any kind of medical exam. So that's step 2. That's kind of that. And although it is slightly different, the stuff you're examined on step 2 CK versus your UK medical school finals, there is a substantial amount of overlap. Right. I mean, medicine inherently, wherever you are in the world, like sepsis is sepsis, whatever, cancer is cancer. There will be slightly cultural differences in the way stuff's examined, but it was not, there's probably an 80% overlap in exams. So that was my way to efficiently do my step 2 CK, which I did. I think my finals was in January, did that in February or something like that. So I thought that was quite efficient. When I sat step 1, it was a pass-fail exam. So it was a scored exam, so I had to do well in it. So I sat step 1 kind of towards the end of medical school, and that kind of like fallow couple of months you have after you sit finals in Manchester, at least. Obviously, the program is different in the UK. So I just basically wrote off 2 months of my life, 3 months of my life, and just sat in a life and advised for it. And I didn't do that well on step 1, but I did well on step 2, so that kind of compensated. And then I sat the OSCE kind of just before COVID in January 2020. And then I did step 3 in the US in 2021. So that was kind of how I got my step 3 done. I matched this year.
So you matched this year. So now let's move a bit more laterally into your working life now and working in the US. So
before we move on there, would you like to discuss the other stuff program select on?
Sure. If
yeah, I feel it might be useful. So obviously the scores is one thing which I think we've discussed. There's 2 other things I think I'd recommend. The first one is to develop a generally good medical CV. So what I mean by that is getting good letters of recommendation from writers in the UK, and then possibly the US, which we can discuss with US clinical experience. The second thing is publications. I wouldn't over obsess about it and make yourself stressed about them and be a type A med student, but they are a universal currency. It demonstrates you have worked hard in there, you've demonstrated interest, you've thought about something and you've worked at it, and a group of your peers have looked at it and said this is interesting. So I would, let's say you want to do psychiatry in the US, I would try and at least get 1 psychiatry publication, just as something to talk about. Obviously, if you're going for more competitive specialities, you might need more to stand out, but it depends what you're going for. Sorry.
It's actually a good opportunity there, because although I've put it at the end of my question list, somebody did ask about letters of recommendation.
Yeah.
That's not really a thing that we do in the UK for any part of training. What do you mean by that?
So in the UK, I think our system is the reference, which is like, yeah, they're a good guy, they're not, I don't know, they do the work, they turn up, etc., etc. In the US, a letter of recommendation is kind of these like essays people write about how wonderful you are, and they wax lyrically about you. So there's a big cultural difference there. So US letters of recommendation tend to carry more weight than UK letters of recommendation. So my approach was I approached my 2 mentors in the UK, and I got a letter of recommendation off both of those. I sent them like a nice letter saying, thanks for your time with me, I really enjoyed working with you. I'm now applying for residency in the US, and then I sent them examples of letters of recommendation stressing that they're very different. And I think I got at Zoom as I matched, I got 2 good letters back. So I would identify your mentors in the UK, develop strong relationships with those mentors, and then use that as a resource to get good letters of recommendation.
Okay.
And then if you can, you should try and get a US letter of recommendation. So I didn't actually manage to get direct US clinical experience due to COVID. So I was going to go over to CHOP, which is Children's Hospital in Philadelphia. But unfortunately, COVID happened, so that was cancelled. But I managed to, in the third year medical school, I worked in Boston as a research assistant. So I got that PI to write me a letter, which although isn't probably as good as a clinical letter, it kind of shows that someone in the US system can vouch for you, so that's important. And then I worked remotely at CHOP doing research and got another letter from one of my supervisors there. So that kind of built a picture of, at least I could demonstrate that I was interested in pediatrics and I was interested in genetics, which kind of hopefully overall worked well.
Do you think that, I mean, you said you didn't manage to get direct clinical experience as a medical student. Do you think that that's important or worth chasing?
It's a difficult question to say. I'd say it helps. I'd say it's a positive thing. Inherently, I don't think there's any one golden ticket to matching a competitive residency in the US. I think it's a collection of good scores, good letters of recommendation, good publication records, appearing well-rounded at interview. So I think this is one of the facets, and it will help your applications. If you have a chance to do it, I think it would benefit you. So I would pursue it, though I wouldn't not apply because you don't have it. Some people will say don't apply because you don't have it. That's stupid. If you've got good scores, good letters of recommendations, you published a couple of papers in your area of interest, you are a competitive applicant. And from my experience, UK trained doctors who've matched in the US have exceeded their expectations in terms of where they've matched. I have a friend who went matched at the Mayo Clinic.
Wow.
Was a good student in the UK, but there were holes in his CV as well. I had a friend who matched at Mount Sinai. Again, he was a good student in the UK, but again, there were holes in his application. So there's never going to be a perfect application. And if you pursue a perfect application, you probably never apply. So I would just work on what you can work on. And if you can get US clinical experience, get it. It's great. But there are other ways to make yourself more competitive.
Grand. So moving on to life in the US then, yes. Dr. Tinker, US doctor. How is, I mean, this is a very broad barn door question that you can answer how you like, but how is working in the US healthcare system different than working in the NHS?
Yeah, it's obviously the NHS is a very different system than the US healthcare system. There's lots of different areas. The first thing is that I think that there's an expectation in the US that you devote your life towards medicine, which I guess we don't necessarily experience in Europe. There's none of this kind of, I don't know, work-life balance. You can kind of have a bit of in UK training. You're there for 3 years as a resident or 4 years, and you're there as a resident of the hospital. You're there to devote your life to the training, which is both good and bad. So that's one aspect which is different. There's no concept of, I don't know, guidance of safe work or anything like that. When you're at work, they expect you to work till the work's done, which is both good and bad. So the work-life balance is more shifted towards work. Maybe that's an extension of wider US culture. Everyone is very work-driven here. So that's one aspect of training, which is different. The second one is hospitals are more efficient, I'd say, in the US. In the UK, when you're working at a really busy hospital, it can be so it can get you frustrating when you're waiting for scans and you're waiting for those kind of things. In the US, that tends to come much faster. So that's becoming more that can be great sometimes. You don't have to wait around for an echo for 4 days. It would just happen this afternoon, which I found a bit bizarre when I first started working here. So that's one aspect. Another aspect is people are much more invested in your career in the US. There's much better mentorship on the clinical side. When I was doing my F1 rotations, I didn't have any personally against any of my the consultants I worked with. You weren't viewed as someone to train. You were viewed as someone to run the ward, keep things ticking along, foot soldier kind of more thing. Whereas there is a very strong culture in US medical education of mentoring you, of taking you forward and making you better, which is both a good and bad thing. Have this concept of feedback here, which we don't really have in the UK. So at the end of most weeks, the attending you're working with comes and chats to you and says what you did well, what you could do better, and what you could continue working on, which inherently is quite useful. But at times when you just had this very busy week, it can be a bit tedious at times. So that's one difference. And there are lots of other differences, just culture as well. But then I'm not sure how much of it is pediatrics versus not pediatrics. I find medicine is very defensive in the US, but there may just be a product of pediatrics being very defensive. People tend to want to rule out more stuff than I found they would, at least in UK adult medicine. There may just be an extension of pediatrics, so I'm not quite sure of that.
Sure. And it's really interesting, and I really resonate with what you say about that. It's rare for someone, especially as a junior doctor in the NHS, for someone to take an interest in your training. I'm wondering whether
I got excellent mentorship in my academic foundation program from my supervisor. Like I probably, if I'd kept working, could have got an MRC funded PhD, which would have been obviously a great experience, a great way to train. But when I was on awards, there was no interest in teaching you to be better. There's even simple stuff like teaching you how to use an ultrasound guided cannula machine, which would be in everyone's interest to stop having to nag an anaesthetist to come down and put IVs in. There was just none of that, and it was just, you were just there to staff a rota, was how I felt on my F1 jobs. Maybe it was me thinking above my station. I don't know. But
well, all I'm wondering,
I would have liked someone to come down, take an interest in me, and mentor you to become a better doctor.
Yeah. What I'm wondering is whether that is a difference in the training culture. That is to say that presumably when you match as a resident in your pediatric genetics program, you're going to be there for 4 or 5 years, right?
Yeah.
Whereas in the UK, because of how our training works, even up to ST3 level, really, where you're, so your F1, F2, CT1, CT2, you're rotating around every 4 to 6 months, and you're not in one place long enough for anybody to actually know you.
So rotation has pros and cons, and in the US, you're very much based at one hospital at most programs. So in terms of the pros of being stuck at one place, or not stuck, being at one place, you get to know the system really well. So you don't. I find it frustrating when you move between different positions in the UK that you have to completely learn how a new hospital works. You learn with time how a hospital works, which is good for continuity and takes the stress away of rotating around. It's also good because you get to know people, you get to know what specific attendants or consultants like, which is also good, and how to kind of work with them to ultimately give the best care to patients, which is ultimately the most important thing. So that's a good thing about being at one centre. It's also, I wanted to do paediatrics, and paediatric venereals is where I train, which is the northeast and the northwest were massive, and you just effectively get moved around lots of different hospitals, which I think can be quite stressful because you just never quite settle down in one place. So that is the benefit of being in one location. In terms of the negative sides of it, in some ways it's quite nice being able to move around, because when there's certain people you just don't gel as well with. Being in a large organisation, there's nothing you can get on well with people professionally, but it is nice sometimes when you have a consultant you don't like, or you have a system which really frustrates you, to know that in 2 months' time this will no longer be an issue. Whereas if you're there for 4 years, you have to deal with that for at least 4 years. So that's kind of one benefit of moving around. And also by moving around, you do see how other things are done differently, which again can be a benefit. And you get to move between, in the UK at least, you get to move between DGHs and tertiary centres, which obviously have their different cultures. I'm only trained at a tertiary centre. I think I could get better procedure experience if I could put lines in myself as opposed to have to call someone up to put them in. So there's lots, because we have obviously excellent ancillary services here at Vanderbilt. So that can sometimes affect your training. So it might be better to have a mix of working at less high academic centres. But then by working at high academic centres, you have access to exceptional research reports. So it's kind of swings and roundabouts depending on what you want from the training.
How's the salary?
Okay, so so you've kind of sold a bit of a lie as a doctor in the US. So obviously everyone has this impression of doctors in the US earn a lot of money, which is true, and I will come on to that in a moment. But as a resident, you make about £45,000, about $60,000 when you start. And it goes up by like $3,000 a year, so you're up to about 72, 73. Obviously it will change with inflation. So the actual money is not that different from what you make as a UK junior doctor, and you have to work more hours, so the actual hourly rate is about the same. Depending on where you go in the US, there are other benefits. The tax rates tend to be lower, and there's a thing called state income tax. I probably pay about 20% tax, and then I probably have to pay, if I was in a high tax state like New York or California or some kind of big liberal coastal state, you tend to pay more tax, and that can be up to 10%. So then you're getting closer to European levels of taxation. But if you end up in a more Republican state like Texas or Tennessee, where I am, some of them don't have state income tax. So then you're paying between probably 10 and 15% less tax than you pay in the UK. You don't get half of that. You have to pay a health insurance premium. So I probably am a bit financially better off than I was as an F1, F2 in the UK, but I'm not substantially. So that's as a trainee. As an attending, the money is much better than you make in the UK, with the caveat that pediatrics is not particularly well paid. So if you want to do a less well-paid speciality at an academic centre, you're probably looking between 180 to $200,000 to $240,000 a year, depending on how much specific clinical time you want to do. So that's kind of the bottom of the pay scale. If you end up doing a heavily procedural speciality in a rural location, you can make silly money up to $700,000-800,000 a year. Kind of is probably the reasonable ceiling. There's obviously caveats where you make less than that or more than that, based on personal responsibility and how much you want to work or what you want to do. So kind of the two things that determine remuneration in the US are if you're doing a procedural speciality and the geographic location you work in, more procedural specialities pay more, and more rural specialities pay. But if you work in a rural area, you get paid more. So those are kind of things that determine your salary. And I'd say a floor of about 160 and a ceiling of about 700-800. The more, as a general rule, it's harder to match into more procedural, more high-end paying specialities as an IMG. But there are specialities which are you can match into and you get very well paid. For example, a psychiatrist who's willing to work in a rural area, which is not that hard to match into as an IMG, can earn $400,000 a year, which is obviously the kind of level you'd have to be an orthopedic surgeon in the UK doing almost exclusively private work for, kind of get to that very range. So if your primary motivation is to make money, which I think is a fine primary motivation, you work hard. I think there's a culture in the UK of kind of ignoring the financial side of money. The US is a good option. So that's one thing. I'd say this is probably more general than answering your specific question. If there's two good reasons, in my opinion, to move to the US to work as a doctor. The first one is if you want to be a leader in your field. So the US academic medical culture is the best in the world. So that's one reason. The other one is if you just want to make a lot of money and have a good work-life balance, because you can do your 3-year residency, which will be tough. The hours will be longer than UK training, and then you can work in a ruralist setting and earn a lot of money.
Fair enough.
In comparison to the UK in a low tax state, and you could, so that's my general advice to people.
Yeah, that's a really interesting comparison. I think what the public perhaps, and certainly it seems counterintuitive to a lot of people that, a psychiatrist should earn the same as a cardiologist, should earn the same as a GP, should earn the same as a transplant surgeon. In the UK, that's kind of how we do it, right? Like everyone earns a flat salary regardless of their specialty or what they do or whatever. And that is one way you could do it. But certainly in the US, it does seem to be, as you say, the case that those more procedural heavy specialties. But then I'm thinking, why is that? Is it because more of the market is private? Is that what
I think
drives it?
I've always asked myself this question, what actually drives the salaries? I think it's a billing issue. I think you can make more money as a hospital if you can do something you can bill for. If you put a stent in or something, that's a procedure you can bill for.
Right.
Whereas there's this concept, someone said to me in the US, that you're not paid to think in US healthcare. So the kind of really important specialities in pediatrics, like pediatric infectious disease or pediatric development, have chronic shortages of attendings because you can't really bill for diagnosing a child with autism, or you can't bill with narrowing down antibiotics in a highly complex child with an abscess, whereas you can bill for putting a line in or something like that as an interventional radiologist. So that can be frustrating at times because there's an abundance of those kind of services in a hospital, but there's a chronic shortage of the kind of more thinking skills, and that permeates to genetics as well, as you can't really bill for diagnosing a genetic disorder. So that can be frustrating at times. Obviously, the UK system, where everyone's paid the same, regardless of how good or bad you are at your job, de-incentivizes people from working hard and really driving their service or their field forward. So that's kind of a different kind of side to it. So that's it's an interesting as a semi-outside of the US healthcare system to see that. And there hasn't been any real attempt to change it.
Fair enough. And then I guess the last thing to ask and a place to close it, Rory, is I think there is an increasing number of medical students who, even from a very early stage in their education, are thinking about going to the US. It's become more of a talked about option than it was. Yeah. What's your advice, your golden tips that you would give to people in that position?
I'd say don't be intimidated by the USMLEs. If you want to stay in medicine and practice medicine, you're going to have to sit a hard set of Royal College exams. So there's going to be a point of your life where you have to sit down and work really hard. I guess you have the decision of if you want to go to the US, you can do that at med school and you can work hard and get the USMLEs done. And then it's like getting into medical school. It's like anything in medicine, like neurosurgery, applications. It's a box ticking exercise at the end of the day. You've just got to tick the things that make you competitive. And if you do that in a systematic manner, I don't think it's much competitive than matching into a competitive speciality in the UK. And my advice would be the US is good for two specific reasons. One, as I mentioned earlier, if you want to be the leader in your field, which is a noble ambition, and some people rightly or wrongly want to do that, and that's for them to make the decision. And then if you want to have a hard couple of years in residency and then have an easier rest of your life, you can work hard for 2-4 years and you can move to a beautiful rural location in a low tax state and earn much more money than you'd ever make in the UK, much less stress, have a fantastic life. So that's kind of my picture of what I've learned, I guess, in the last couple of years of doing this process.
Perfect. Well, thank you, Dr. Rory Tinker.
Thanks. I hope this can help people who are, I don't know, at some stage in medical school thinking about it.
Yeah, it definitely was. And I think, as I say, I certainly, as I got towards the end of medical school, I noticed an uptick in that becoming more of a palatable option for people.
Yeah. I mean, there's definitely a culture in the UK hospitals of, oh, America, you deny people insurance and they die. And it's not really the case. The US insurance system is frustrating sometimes to work for, and there's annoying aspects of it. I think I deliver better care here than I did in the UK, at least, and that is more satisfying.
Well, thank you very much for coming on, Rory. It's been an absolute pleasure. It's lovely to see you again. It's been what 6 months?
Yeah. 6 months, so yeah.
Yeah, well, take care, Rory. Are you happy for people to potentially leave comments on this video?
Yes,
or to
of course. I can try and answer them, comments or contact me is fine.
No problem. We'll put Rory's socials on the overlay as well, so you can get in touch with Rory if you want to. Thank you very much for coming on. Take care.
Thank you.